I have to say it is an extraordinary honor to be here today. And the reason it's such an extraordinary honor is because Community Access has really been delivering on a promise that we made 50 years ago. So if you go back to basically when we as a society decided to say we're going to close our state mental hospitals and we're going to move care into the community, a promise was made. And the promise was decent housing and really help people live full lives. And Community Access has now been doing this, I think, since 1972, is that correct? And that's why it's such an honor to be here, because you are delivering on that promise. So God bless all of you, and you should be proud. It's a great organization. The book, I'm going to talk about this book, and the book does have a sort of big sense to it. And to put it in perspective is that even going back to that time when Thorazine enters asylum medicine in 1955, we've had a certain paradigm of care, where increasingly medications have been at the heart of that care, sort of drug-based care. And what this book really does is look if whether that paradigm of care, or where medications are sort of central, how is it working for us as a society? And of course that means how is it working for individuals as well? And as I look at that question, it may be that maybe we could think of a paradigm of care that was slightly different, or maybe even radically different. And the question is if the evidence that we have now of 50 years following this path, is it going to tell us that it's working well or not? And that's really part of what this book is about. It's a very fundamental question that I'm asking here. Now, the common understanding in our society, and it's, by the way, it's one I certainly shared 10 years ago at the start of this whole adventure, was that, of course, it's working. The understanding is that when Thorazine arrived in asylum medicine in 1955, that kicked off a psychopharmacological revolution. You can read in some history books that the arrival of Thorazine is as important as penicillin was in internal medicine. An extraordinary leap forward. The common understanding is that thanks to these medications, it made it possible to empty the state mental hospitals and for people to live in the community. And then, of course, we've heard the story that in fact these drugs, even if we look at the names, they're antipsychotic, meaning they're sort of specific antidotes, antidepressants, specific antidotes. And well, of course, there's a belief that they fix chemical imbalances in the brain, and if that's true, that indeed is a great advance because you've identified a pathology and now you have a treatment for it. And as part of this understanding, and we sort of believe this revolution in care took place in two steps. We had the first generation of drugs from that's Thorazine, the tricyclic antidepressants, etc. And then in 1987, Prozac came to market. This was the first of the second generation drugs. And these drugs are said to be, the second generation, even another step forward, more safer and more efficacious than the first generation. So the story we believe in is really a story of medical progress. And if you would have read David Satcher, he was the U.S. Surgeon General in 1998, I think his report was, his mental health report. He sort of told this story. And he said, back in before 1955, psychiatry lacked treatments that could prevent people from becoming chronically ill. Now we have these treatments that in fact help people lead relatively normal lives. Okay, and we said we have safe and effective treatments for a vast array of nicely defined disorders. So that's the story of medical progress we believe in. And again, I would like to say in 1998, I co-wrote a series for the Boston Globe, and it was on the abuse of psychiatric patients in research. And one of the premises of that series was looking at studies where they had withdrawn antipsychotics from schizophrenia patients. And we were saying that is incredibly unethical and abusive because you would never withdraw insulin from a diabetic, so why would you withdraw antipsychotic medication from a person with schizophrenia? So that's my starting point for this long intellectual sort of journey I've been on that is going to arrive, frankly, at a very different place in this book. But I want you to know I began there. Now, what's the puzzle that is at the heart of this book that sort of sets off this journey? It's this puzzle. The first thing I did in this book was just look at the number of people under government care, which is sometimes called the, people with the disabled mentally ill is sometimes labeled, but let's just say people under government care due to a mental illness. Now, if you go back to 1955, there were roughly 560,000 people in the state mental hospitals. If you dig into that number a bit, though, there's actually only about 360,000 people with psychiatric diagnoses. There's about 200,000 Alzheimer's, people with alcohol-related problems, in-stage syphilis, etc. So 360,000 at the beginning of this revolution, okay? Now, of course, we switched to community care, and the way researchers have tracked the number of, quote, disabled mentally ill is looking at the number of people on SSI and SSDI due to mental illness. And you can see that's sort of why they do that. Now, in 1987, that number had grown to 1.2 million. It's an increase. Now, since 1987, when we got the second-generation drugs, and we really embraced this form of care, the number of people on SSI and SSDI has tripled to 4 million. It is now increasing at the rate of 850 people per day, 365 days a year going on SSI and SSDI due to a disability, because they've been disabled by a mental illness. So you can see the paradox here right away, right? As this revolution has unfolded, the one we say that prevents chronicity, we're actually seeing numbers that tell of an epidemic of chronicity. So the question is that I'm looking at is, why is that so? At the very least, it begs the question of whether this revolution really has played out like we might hope it to play out. And by the way, one other bit of data. In 1987, there were 16,200 children receiving SSI due to a mental illness disability. That's when we began medicating children. Today there's 600,000. 35-fold increase. There's 250 children going on SSI every day now in the United States. And if you follow them forward, when they hit 18, they're going right on adult SSI, SSDI. So you can really see this pathway that's forming in our society where kids get diagnosed, and next thing you know, they've got a career as a mental patient laid out in front of them. So here's really the puzzle, I think. We have this story of, that there's been this psychopharmacological revolution that greatly improved outcomes. And there's other thing I think we have to acknowledge. Yes, can drugs help people through? We know this to be true. We know that drugs often do help people in times of crisis. We see that. We also know people who've stabilized well on medications too. We see that. We know that. But yet, in a big picture way, we have this other problem of increasing chronicity, increasing disability numbers. And so it really raises this question. Could our drug-centered form of care, for some unforeseen paradoxical reason, be actually fueling this rise in the number of disabled mentally ill? Okay, I think you can see it's a legitimate question. And then when you ask that question, what you're really going to want to see, and you're going to want to see what science can tell us, is how does this paradigm of care, how do medications alter the long-term course of mental disorders? So how do they alter the long-term course of schizophrenia, of bipolar disorder, depression, anxiety, etc.? Do they alter it for the better? Do you see employment rates go up? Do you see symptoms, are they less symptomatic, more symptomatic, that sort of thing? Do you see cognitive function improving in the modern age or deteriorating? Those are the sort of questions you want to ask. That's the first question we're going to see if we can find in the scientific literature. And I think you see it, this is an evidence-based approach, all right? And the second question is this. Another possible problem is, let's say, do we have a form of care where you take someone who has say a mild problem, say they come in with a mild bout of depression, okay? That's their entry moment. And they're put on, let's say, an antidepressant, and a certain percentage of people may have a manic episode in response to that antidepressant. At that point, they may be diagnosed with bipolar, and now they're into a much more serious category. So one of the things may be happening, this is a possibility, is that we're taking people with milder problems at the beginning, and at least some people are getting pushed into a much more serious category. And as you know, if you end up in the bipolar category today, you often end up on a cocktail, and that is really a serious shove into seriousness, as what one person told me. So that's another possibility we want to look at.